My talk's going to be quite different to that, because I didn't even actually understand much of that talk. My brief was really to, I guess, pan back a little bit and give you, I guess, more of an overview of how outbreak response works. So, as I say, it'll be quite different, but then you can go back to your very technical, complex talks. So this is, it's easy to forget in a way, I guess, that the pandemic had 15 million excess deaths and $16 trillion lost by governments, and that's money that can't be spent on health systems, on schools, things like that. There was some places lost a year of schooling. The global poverty index went up for the first time in 20 years. So, you know, it really was catastrophic, and now that we move on to other problems in the world, it's easy to forget it, and I think it's the responsibility of us to really not let that be forgotten. So this is, I'm just going to talk along those lines. So this is a nice slide of Uganda at the end of a Ebola outbreak, and you can see, have I got a, is this gonna, yeah, you can see here there's a little sort of notice board, you know, amongst teams of contact tracers and all the multidisciplinary groups here. But if we hone in on that notice board, you can see this was how 25 years ago you ran an outbreak response. These are the pillars of outbreak response. And if you look at the central one is coordination logistics, social mobilisation, surveillance and epidemiology, case management and laboratory. Really simple, okay? Do you see anything about research? Do you see anything about vaccinations? Do you see anything about social media and misinformation? No, because it's become more complicated, and now, 20 years later, we look at something like this, where really key in the middle is these leadership pillars with coordination, operational support and research innovation. And we saw how there was so much pivoting from, I guess, conventional, the research you were doing, turning that into research which would direct policy during the pandemic. But then around here, we understand now that you can't just go for COVID and forget about cancer screening and all that sort of thing, you know, heart attacks, and a lot of the excess deaths weren't to do with COVID. So, and social services, family planning clinics, you can't just stop those or you end up with all the unwanted pregnancies at the end of the pandemic. Vaccination is its own pillar now, and we see how we've gone from what we just did and CEPI's 100-day plan, which is going to really revolutionise that if we can get it through people's heads that this is a good way to go. IPC and protecting the health workforce. We've still got surveillance, labs and diagnostics, case management. Mental health has become much more prominent. This is something we're still not good at, whether it's patients, whether it's families, whether it's people losing their livelihoods or the patients themselves that are in isolation for a long time. And of course, arguably the most common, most important is risk communication and community engagement. How do you work with communities to ensure that you're working as one? And infodemic management, all that information that's coming at you, how do you manage it all? How do you sort it out? So you can see it's a lot more complicated now, and you really have to review each of these pillars of outbreak response within the 4 phases. So everyone thinks about response because it's in your face, you do it. But we also know that preparedness and prediction, these sort of things are that foundation which allow you to respond. Then this is the phase that's often was left out by many countries, that readiness phase, that period when you've got your first couple of cases or you've got no cases, but you know they're going to come. What do you do in that period when you know it's coming? And I can tell you, as we know, most of the world waited until they got smashed and then started panicking, and it was already too late to do contact tracing because they had too many cases already. And then, of course, there's recovery, which feeds back into preparedness. So I quite recall this slide. This is 31st of December at 7 o'clock at night, and Thomas Lowe, who many of you will know, who's the group CMB for NUHS, writes to me asking if this is something we should worry about, this China probes pneumonia outbreak for SARS links. So this was the first sort of stuff coming out through ProMed about the outbreak to the rest of the world anyway. And Thomas does that, and I write back to him. And so the point I'm making is that countries that are onto this right at the start will prepare better and be ready. So the readiness has to be across whole of government. You can't just call this a health problem. I think we all know that. And their first meeting in Singapore was on January 23rd, which coincidentally was the same day as the first case was identified in Singapore. So what do you do in the readiness phase? Well, in all these various things, the health sector, review your plans, what are your surge capacities, do some scenarios, and we were so busy preparing. What if someone with suspected COVID comes in labour or something like that? What are we going to do with them? The non-medical sectors need to establish their own systems. Early identification, getting that triage right in all the places where you can identify it. Establish all your communication conduits, scenario planning in healthcare facilities, and really getting everyone ready to just accept that knowledge is going to change and decisions we might make today could be proven to be wrong next week. But so you need to help people understand that. And you can do all this in that readiness phase, which for COVID was really January 2020. The next one I just wanted to touch on was leadership. It's really not hard to remember these three scenarios. There was no respect for what experts in outbreak preparedness and response were doing. So we all know of the 10 Downing Street parties while everyone else was in lockdown, Bolsonaro, Trump telling people to inject disinfectant. There were really just a lot of absolute madness, and you just wonder what was the strategy in so many countries. Of course, US and UK are repeatedly on the Global Health Preparedness Index, repeatedly number 1 and 2. They are the most prepared countries in the world. And still, even though that's a very static measure, and once you start to put it into place with poor leadership and poor coordination, you realise no matter how well prepared you are, you're still going to falter. You have to change your whole leadership structure because everything's different. And this is the WHO incident management system. I won't go through the details, but a lot of these things actually change when you're having an outbreak. So there's whole departments you didn't need before, departments that might examine more, verify tests, for instance. So you've got a lot more things, EOC management, external relations, staff health and well-being. These all need to be amplified, and you can do that bearing in mind that each of these cells, how do you design it? You must be wary of choke points, because if someone is if a leader, a decision maker is overwhelmed with decisions, then you're not going to get decisions made, and that's how things can falter. So just for example, a narrow span of control, as seen here, is very more vertical. So, and this might be for more complex tasks. And then you've got a flat structure, which is a wide span of control. So that might be someone managing a team of contact tracers, for instance. They've all got very similar tasks, and you can all just report in. So this IMS structure and designing your cells is a crucial part of leadership, and I would argue most countries didn't adopt this. They just tried to manage within their existing structures. So this was our multi-ministry task force that presented to the country every week, a great example of community engagement. They would understand the sensitivities at the time and be addressing those. So just as this talk is called, about the pitfalls, So I'd say the readiness phase, the non-recognition of that was probably the biggest. Leadership and coordination also faltered in many countries. Where these were done well, the countries did better. Obviously, you all know about the politics, the geopolitics, the nationalism, and that's being addressed in some ways, such as in vaccine manufacturing being a little bit more dispersed rather than just seated in large countries that were going to obviously spend most of the vaccination and the testing and things on themselves. But then there's quite a number of other things. Care for the vulnerable. We know our dormitory outbreaks here could have been managed better. Mental health, the private sector was hardly involved at all. Countries without the whole of government community response, misinformation management, community engagement, overwhelmed health systems. UK had some great examples of, just the high number of people that were admitted to hospital and the high death rates from hospital-acquired COVID. So once you get overwhelmed, then whatever the death rate is, you're going to find the case fatality rates increase significantly. And of course, post-COVID, we're probably struggling less now, but all the airline failures, lots of businesses failing once the financial support was removed. So I think there's lots of pitfalls, lots of areas we can do better next time. And of course, this is all confounded now by the US or the Americas and Europe's approach to global health. So we know that US is traditionally a major responder for that. I'll just, you can pause on all those, but USAID, CDC are told that no more international work, and probably 1 million people, 1 million healthcare workers across Africa losing their jobs, all the antiretrovirals not getting to patients anymore. So people are clearly going to die from this. And this is just the US. We've got other countries. Argentina's going to be, also wants to leave the WHO. Italy's far-right party is planning on it as well. France and Germany have cut funding, but they're more budgetary because people are just realising they've got their own financial problems. Sweden is a bit more ideological. That's cut off all its promised funding to NGOs. A lot of UK are diverting funds to the defence budget. The European money that used to go into global health is now going towards the Ukraine effort. So we're in quite a bit of trouble financially, at a minimum in the short term. And this moves on. The World Food Programme's lost 30% of its money. ICDDRB, a research organisation in Bangladesh, has lost 1,000 staff, and China stepping in as probably the only country that I'm aware of that's increasing support to the WHO. We published this. There's quite a number of people from international organisations, and we published this in Lancet a couple of months ago about things that we should do on the basis that all the money's being withdrawn for outbreak preparedness and response. So this is like some of the areas, this is called mobilising national and regional assets and non-state actors. So that's us, okay? That's academics, that's research facilities. What can we do to step up in pandemic preparedness and response? And I just want to give some examples. This is one I'm personally involved with, health systems capacity building, establishing regional capacity training and education hubs with sustained funding. So can we do that without the WHO, without the regional offices of WHO, without IFRC and UNICEF? How can we do this? And the first thing we've done is create this textbook, which is the first time there's actually been recognition that this is a body of information that you don't just fumble your way through, there's ways to do it. So there's 39 chapters, it's about 600 pages, and I've got about 100 senior authors that contributed to it. It's had a nice review in Lancet already, and I think there's more journals coming. It's getting reasonable uptake. We're getting about 3,000 page views a month, about 2,000 unique visitors every month. It's available free online, and you can see there's a fairly global reach, so the top countries are here. So I think this book is a body of knowledge which helps recognise the pillars of outbreak response, and we've turned that into a master's course now. I won't go through the details of it, but suffice to say, these are the sort of areas that we're teaching in. We've got a large faculty, so this is very flattering when you see all these world greats are prepared to contribute, either in person or virtually or however. So we're probably going to end up with 80 or 100 faculty across the whole thing. We've got our first cohort of people just started, and there's a couple in the room. We've got 37 people representing 14 countries, huge diversity, and that's where we are. So it's really about creating the body of knowledge for outbreak preparedness and response, having it identified as a discipline, and we need to create and have recognised more experts in the field rather than just people fumbling their way through. It is a science, it is real, but because it's become more complicated over the last 20 years, it's justified taking it this extra step. So with that, I'll sign off. So thanks.